So talking today about recognising and diagnosing dementia in primary health care, and I've chosen to start the first slide with the forget-me-not flower, which the Alzheimer's Society use as a symbol of remembrance. And Google also tells me that it's a symbol of going on a journey with someone as well, which is probably appropriate for the relationship that you form when you sort of initially diagnose someone with Alzheimer's in the community. So what I'm going to talk about is why it's important to have an early diagnosis, how we might come to that diagnosis, so just the workup, and I've tried to run it like a consultation, identifying some of the risks, and there are quite a few risks, and it can be quite a scary area. How to deliver the diagnosis, appropriate referrals to secondary care services, and some self-care. So I can appreciate that this is a simplified diagram of the dementia process. You see that it starts in the community, and most of the care is delivered in the community. As the disease progresses, there's a greater likelihood that the person will be cared for in aged residential care. So while there would be lots of boxes at the end of as well, we're just, for this talk, focusing on the blue boxes and the beginning of the patient journey. So why early diagnosis? And essentially it's like all things. If you diagnose something early, then you can have planned care. If you diagnose late, then it's reactive care, and it can be more fragmented and it can be more stressful for the person. An early diagnosis of dementia has been shown to slow down the rate at which the disease progresses. So you can put implementations in place to help the person. It decreases falls, it decreases care stress, and it can help with medication management. You can also engage the person early in processes like encouraging them to do an enduring power of attorney and advanced care planning. Early advanced care planning for people with dementia is very important because they need to be able to engage with the process, and the sooner that you start that, the better it is for them. The start of care focuses on diagnosis and the exclusion of any reversible causes, so making sure that there's no underlying condition that's causing the memory impairment, and serial assessments. As the disease progresses, then we are trying to maintain functioning for that person, helping them in the community. So you might get some people who present to you with subjective memory impairment, so they have an awareness that things aren't quite as they used to be. And for these people, it's important to not say, oh, that's normal ageing, it all happens as we get a little bit older, don't worry about it. It's a good opportunity to engage with some cognitive testing, and to help them put, processes in place to manage. So you need to encourage exercise, healthy diet, keeping social, all of those kinds of things, and optimise disease management, so diabetes, any vascular risk factors. It's a good opportunity to be able to get on top of those. So mild cognitive impairment, the definition of mild cognitive impairment is where you have a person who is not scoring so well on their cognitive testing. So there's a demonstrated change in their level of function or on testing. People around them are noticing that things aren't as they once were, and their family are noticing. But people with mild cognitive impairment are still functioning in their home. And that's the difference between a mild cognitive impairment and dementia. You progress to dementia when you have a deviation of cognitive functioning from their normal baseline, and there's no other reason for that, and there's a decrease in functioning, so the person's starting to not function at home. There's about a 10% conversion rate annually for people with mild cognitive impairment into mild dementia. So if you look at the prevalence by practice, it will depend on the size of your population over the age of 65. A rough guide though is if you had 1,000 patients, then about 1% of those, or 10 patients, will have dementia. 3% or 30 patients will have mild cognitive impairment, and of those 10% will convert to new cases annually. So if we think about that, and this is where I'll put some questions to you, what might make you suspect cognitive impairment at a consultation? If someone's coming to see you, what would make you suspect that there was cognitive?
If they didn't come on time or forgot the day.
Yep. Anything else?
If they look a bit untidy compared with usual.
Yeah.
At least they got out of bed at 7 in the morning.
Does anyone else have any triggers or anything that they think something's not right? Because not everyone turns up for the purposes of having their cognitive impairment diagnosed. You know, they might be turning up for their 3 monthly scripts. They might be turning up for all sorts of reasons. Why would you think, oh, I'm gonna ask them about their memory and how they're...
Relatives might bring a problem.
Pardon me?
Relatives might bring a problem.
Mm-hmm. So other people noticing and saying at the consultation. So as you said, unkept impairments, not turning up, just vague conversation. In 15 minutes, it's quite easy to bluff your way through a superficial conversation. And it's not until you drill down a little bit deeper in the conversation that you realise that there's not maybe a lot of substance behind what the person is saying to you. Also, anyone who's been diagnosed from hospital with delirium is another red flag. So there's a high conversion rate as well from people who've had an episode of delirium to developing cognitive impairment. So if your patient's been discharged with a hip replacement and on the discharge summary, you know, they have had an episode of delirium, then it's worth just following up, you know, with some questioning and maybe some cognitive assessment. So what I've got on the screen here is on the MedTech, our patient management system, and I'm assuming most of you probably have a MedTech similar or something similar. This is the start of the consult really, and this is before you even ask the person what they've come in with. You have a whole list of things that you're supposed to be checking, you know, monitoring renal function, their blood pressure, flu vax. There's a whole raft of things, and that's before you even sort of get down to the nitty-gritty problems. And I guess that was there just to illustrate the busyness of general practice and just how that can be a barrier as well to asking those questions and putting it out there. And so that's one barrier, I guess, is time. Are there any other barriers that you sort of feel are aware of?
It's quite confronting to your relationship with the patient. You know, you kind of like to act as their advocate, be colluding, you know, and it's quite a shock to another. I find, you know, someone that I find when I discover that their memory's not, it's kind of a bit shocked. You know, it kind of changes the way that they might see you, or you might see, yes, just.
It is a tricky subject to broach, and it has a lot of ramifications for the person, and I guess, and their lifestyle really. So some of the solutions, I guess, that I thought about was that it's quite good to be aware of different funding streams as well. So Alzheimer's is a chronic, life-limiting condition. So we have Care Plus in Whanganui, and I'm sure some of you have other funding streams as well. So you can utilise that because it can take a while to do the workup. So you might want to bring people back for 2 or 3 consultations and then have a 30-minute consultation to deliver the diagnosis, possibly. So looking at those kinds of things. Training up reception staff to notice that, you know, usually Mr. Brown can use his EFTPOS machine to pay the bill, but suddenly he can't. Do you know what I mean? Just noticing all of those things. And I guess having a good team, like we do talk about an informant interview soon, and while the informant interview is running, you know, you can have a GP doing a part of that consultation and the practice nurse doing another part, so that you're utilising the time wisely. I would be suggesting that you have a low index of suspicion for cognitive impairment. So just asking the question of the person and their family, are you noticing anything different? How is your memory? There's quick screening, so there's the GP cog and the 6 CIT that are short sort of 5-minute screening tools that you can use. And GP, there's a couple of things in general practice that lend themselves to asking the question, and one would be the driver's medical. And people presenting just for their scripts, there's a bit of opportunity in that consultation to ask the question as well. So in Whanganui, we use collaborative pathways, as does a lot of New Zealand, and the one that we use is the map of medicine. And the benefit of collaborative pathways really is that they're a way of standardising evidence-based practice, but you can add a local flavour to them. So our map of medicine talks about referring people to Alzheimer's Whanganui and supporting families, those kinds of things. The maps are designed that you can dip in and out of them. So even though I put a sort of a linear line of the disease process, people don't always present nicely at the start of it. They present in different places, and the map allows you to go and jump in and out of that. So what we use in conjunction with our map of medicine, and it's a tool that's available to general practice, is our advanced form for diagnosing dementia. You can link into the map of medicine from that. You can probably see on the slide, and it just gives you a succinct way to work through the consultation. Again, it doesn't have to be done in one hit. So if you had someone presenting at the start with some subjective memory impairment, you can put your initial findings into this, and then as you screen over time, it will add it. It can be saved as an outbox document, so when you go to refer to secondary services, it's all there for you, and it will have your cognitive screening listed and dated as well. And that's quite useful as well.
Is that something that you've made locally, or is that available on Medtech?
No, it's something that we've developed locally to aid, saying that though we're quite good at sharing. We've got an advanced.
Map of medicine is actually a UK tool, so there is a standard sort of map of medicine.
So I was meaning more the.
And then you can adapt it, so when the decision was made that was what we were going to use, a group of people with a vested interest came together, and it's obvious things like making sure that the phone numbers that people need to ring are actually local phone numbers. So you adapt it to your needs, and there is a map of medicine website that you can access and look at the different maps. And as Rebecca said, the actual, when you come to use the tool, you do it through your patient management system.
We've got another form as well, Jan, that we've added in there, which is the advanced form, and it's based, so it follows our map of medicine structure. And if you're interested in that, I can give you the number of our IT guy. So the picture there is of the informant from the Informant movie, and I guess sometimes the informant does feel a little bit like that. It is quite difficult to talk about someone when they are in the room. People do feel quite uncomfortable, and they feel quite uncomfortable expressing that maybe their loved one does have dementia, or that's what they're thinking. And so it's quite useful when you're taking an informant history to split up your patient and your informant. And this is where it can, it's good to have good teamwork. So the practice nurse can be, checking a sitting and standing blood pressure for postural hypotension, doing a mocker or an initial screening tool, while the general practitioner talks to the informant and gets a history. And the kind of history that you're wanting to get really is a history over time. When did the symptoms start? How long have they been going on for? Are they gradual? Are they sudden? Are they stepwise, or are they fluctuating? So all the time you're trying to work out whether it's a delirium, whether it's a dementia, or a depression. Asking about what's being forgotten. So is it recent events or conversations, or people's names? Can your relatives still use the TV remote? Can they still use the microwave? can they learn new information? You know, can you go out and learn a new skill together? And there's the IQ code, which is a formal questionnaire for doing that, and the informant or family member can take that away as well and bring it back to you, which gives you, it asks them to compare what they're like now as opposed to 10 years ago. And just getting a history from the individual as well, like what do they think is going on, and comparing their kind of take on the situation to the informant's. So your physical examination really is going to sort of be reflected in what the person's presenting with, and we'll talk about that in a minute. So investigations, so again, it's all about excluding everything else and being left with dementia. So blood tests, as you see there, and considering, if appropriate, HIV or syphilis etiology. A urine, and that's just to rule out a UTI. So a 5-minute neurological exam, and that's just making sure that there's no, no sort of focal etiology, so when the person walks in, you're looking at their gait. Do you think that they have Parkinson's? Do they have a slow festinating gait? Do they have a broad-based gait, which you might be considering vascular type causes, or if it's associated with, you know, early onset incontinence as well. Cranial nerves as well, looking for asymmetry. So you're wanting to know whether you should CT scan this person. And again, you just need to check your local guidelines around CT head. In Wanganui, our general practitioners can order CTs for the purposes of diagnosing dementia. And just consider a chest x-ray or an ECG to rule out other causes.
So how would you screen for depression?
You can use the older adult depression screening tool. If you're still not convinced, you can get a secondary care, so a psychologist opinion or a psychiatrist opinion. If you're early on in the process, so your usual screening tools for depression. The initial cognitive screen at the start, because if you're just engaging someone in conversation at the beginning, you might not want to sit there and go through the whole mocker, but just doing short cognitive screening is a way of knowing if you need to progress to a longer assessment, such as the mocker. There's lots of assessments available. Probably the most common one that we see is the mocker. And I guess that's useful because when you're referring or speaking to other agencies, they know what you're talking about and they can make sense of the scoring. So risk assessment can be quite frightening. And again, it's speaking with family, but there's risk with household activities. So worrying about fire, putting something in the microwave for 75 minutes as opposed to 7 minutes. That was one I had not so long ago. Driving, and again, you just about do a whole PowerPoint presentation probably on driving and discussing taking someone's licence off them. Other household activities like chopping wood, and this gets quite difficult as well because as a dementia progresses, you want people to be doing things that are useful and meaningful to them, but it's how to direct them to things that are safe for them to do. Financial worries or financial risks are problematic as well. And so again, asking your informant, asking the person how they're paying their bills, has their phone been cut off, are these things still working for them? We're a nation of hunters really, particularly in regional New Zealand, so asking about firearms, it's not particularly uncommon for people in New Zealand to have a firearm, particularly in regional areas. Malnutrition can be problematic, so getting to the shops, if people sort of lose the ability to initiate tasks, are they going shopping? Falls, And so falls can be related to their gait. It's also, it's a good opportunity to look at medicines as well and medication management. And there's a real risk of isolation, and there's also elder abuse as well, which can quite often take the form of financial abuse for our older adults. So as I said earlier, you could consider making an extended consult to give the diagnosis, and that just allows time for the person and for the family to ask questions around the subject, and it gives you time to explain all of the testing that you've done and how it's led you to this diagnosis. I think it's important to explain that it's not normal ageing. There is a little bit of forgetfulness with normal ageing. You might forget your great-grandchildren's names, but you can function and carry on. So this is not normal ageing. It's a difficult thing to say, dementia. It does carry with it historically a lot of connotations for people, but giving it a name does allow people to access services, which I think is important. And referring early to your local Alzheimer's Society or similar agency is particularly helpful as well. In New Zealand, in Wanganui, we have Alzheimer's Wanganui, and we have our DHB actually funds courses from them for people and their families with dementia. And so they get out, they get to be social, there's some respite care for carers, and it just helps them navigate through the system as well. And they get to speak with people going through the same process. As required, referrals to the needs assessment team. And again, people are staying at home for quite a long time with this disease, and even if the person doesn't need personal care, it's a way of linking in to get respite care for families. Particularly important is the enduring power of attorney, and it needs to be discussed very early on in the process. That way, the person can A, appoint one, but B, talk to them about what their wishes are for the future, which links into the advanced care planning and advanced directives. And it seems, on the face of it, a little bit sudden to be introducing this early when you've introduced this concept of dementia, but there is quite a lot of research showing that it is comforting for people and their families with dementia, because they feel a bit more secure about the future if they can preempt and think about what's going on. So when to refer to a secondary care service, and basically for any behavioural psychological signs of depression where you're not easily able to manage these or get on top of these, and they are quite frequent, especially as the disease progresses. At the early stage, they might just be a lack of being able to initiate tasks around the house, and you can help families talk through that and manage that. So it's not the person being frustrating or annoying, even though it can feel like that. It's actually part of the disease process. Behavioural psychological signs of dementia. So anyone who's deteriorating rapidly, so Alzheimer's typically follows quite a slow and progressive course. So if something is happening quite quickly, then you need to refer into specialist services. Anyone with symptoms from an early age. Anything that's atypical, so language or translation difficulties, anyone who needs a translator to do the assessment process, so to do the mocha or do any cognitive assessment, it's quite good to have impartial interpreters, because if you use a family member, then they can feel like they want you to know what they want you to know, and so they can influence the information that they're giving back to you. Anyone with a past significant head injury, chronic neurological disorders, intellectual disabilities or specific defects as well. So in primary care, the expectation really is that you'd be able to diagnose non-complex Alzheimer's or vascular dementia and feel comfortable with that, not to be sort of subtyping other dementias.
Excuse me, Rebecca. Has there been any research on family violence and the history of dementia?
As in family violence leading to dementia? I haven't read anything specifically about that. I have heard, sort of as I've been out and about in other courses, that there's a strong link between sort of stress and leading a stressful life and dementia, but specifically abuse. I guess if you'd had repeated head injuries or repeated strangulation, those kinds of things, but sort of emotional or verbal abuse or financial abuse, I'm not sure. Yeah. So in summary, oh sorry, I'm jumping. So I just wanted to talk about self-care really, and that was self-care for the carers. So carer stress is, it probably occurs in most families where someone has dementia. It's an incredibly difficult path for carers. So again, linking them into services like Alzheimer's Whanganui. We also have supporting families in Whanganui. Encouraging them to use respite care if they feel comfortable, to get a break. As well, for the clinicians who are looking after those with dementia, again, I think you need to have a tight sort of general practice group, because when you look at risk management, the risks are quite significant. And I think you need a team to be able to talk about that and discuss it, especially when you're looking at things like, do you need to enact a welfare guardianship, or where you're looking at, the EPOA becoming active as well. So tight relationships within your GP practice, working together as a team, but also good links with secondary care services and your NGOs like Alzheimer's Whanganui. And it definitely takes a village. Like the prognosis or the disease is 8 to 10 years from the onset of symptoms. And we all need to be supporting each other really to help each other get through that, to navigate the process and to help the patient and their family navigate through the process. So in summary, an early diagnosis is important because it allows for planned care really, as opposed to reactive care. And it just makes it less stressful if you can have some consultations, 2 to 3 consultations at the start, rather than in the middle trying to pull everything together. I think using the advanced form as well allows you to have everything together, so that when you do send it out into secondary care, if you need to, it's already there for you. You don't have to retype another letter or look back, because it can be maybe a workup over a couple of years. It's there for you. So when you're talking to the person, just talk about the time frame of the symptoms from both the person who's presenting to you and their family or friends. Just list any change in functioning and your cognitive screening and serial cognitive screening. Most secondary care services like to see the MOCA or the RUDIS so they can see where the deficits are. Do your diagnostic testing with your bloods and your MSU, CT if you need it, your 5-minute neuro exam and cognitive assessment. And all that's just to rule out anything else. If you've ruled out everything else, then you're left with a dementia as a diagnosis. To give the diagnosis, your 30-minute extended consult, and referring on to somewhere like Alzheimer's Whanganui. A risk assessment, and then your referral to secondary care. And just remembering that it does take a village, and it's a really difficult thing to do as just one person, and to use the resources that are available to you.